Good afternoon. Hello. So Elena, unfortunately, is unable to attend today because of feeling unwell. So I stepped in at the last minute, so apologies if I'm somewhat incoherent. Anyhow, so the study I'm going to talk about is called the ESCAPE trial, which is funded by Yorkshire Cancer Research, and it's run in collaboration between University of York and UCL. To just tell you a bit about the participants, this study is a two-phase trial. So we have just completed the feasibility part, phase 1, and we're in negotiation with the funder, and you will see why we need to negotiate with the funder, to see whether we move on to phase 2, which will be full RCT, which would become the largest RCT of a smoking cessation intervention in Europe for people with mental health problems. Because the target sample size is over 600 participants. Anyhow, so for this feasibility study, we were looking for adult smokers who were receiving treatment for mental health problems and who were willing to address smoking, but they didn't have to intend to stop smoking. So it's a harm reduction trial, really. The exclusions that we had here were that participants could not have had a recent inpatient admission in the last 3 months. That's because of concerns about follow-up and dropout. They couldn't have comorbid drug or alcohol problems or currently using e-cigarettes already. So we recruited participants primarily in secondary care and in community mental health teams for people who were attending either annual care program, review meetings, or annual physical health screens. We also included one site in Sheffield, which was a primary care site for participants who were attending annual physical health screen for those with mental health problems. Procedure was we approached participants, or we identified participants prior to mailing them, going through the inclusion-exclusion criteria. Then we mailed them, and then we called those participants up to check their eligibility and consent them into the trial. So the actual consent happened all in the one day when participants came into the primary or secondary care healthcare setting, where they were consented, gave baseline measures, were randomized into the intervention control group, and also received the intervention from a clinician. The intervention itself is e-cigarette-based intervention, so we provided participants with an e-cigarette starter kit. There's an older version here that we use, and this is because this was the only, at the time when we applied for the funding, the only e-cigarette that had been tested in a clinical trial by Peter Hayek to found to be effective in a general population sample. And we offered them a mix of 3 flavors and 3 strengths of nicotine. In addition to which, they also received a bespoke information leaflet about the e-cigarette, an in-person advice, about 5 minutes from a clinician, and then also very brief advice from the clinician to stop smoking. As I said, however, participants were not required to set a quit date or to want to stop smoking, just to address their smoking behavior. The control condition was care as usual, which varied quite a bit across different sites, and very brief advice to stop smoking, and we also recorded differences in care as usual across sites. Now, this is a bit of a busy slide, but these are our outcome and success criteria. In red, you see the criteria that we used in order to justify progression to the full trial from this feasibility trial. You can see that we wanted to recruit about 6 participants per month per trust. We wanted to consent at least 15% of eligible participants. And we wanted to follow up at least 70% of participants, so an attrition rate no greater than 30%. We also assessed acceptability both qualitatively and quantitatively. And our efficacy measure, or outcome measure, was CO-validated sustained 2-week abstinence at 5 weeks. And so this is the standard stop smoking service outcome. And we calculated our sample size based on a one-sided confidence interval approach. I'll tell you a bit more about it when we get to the results. We also had some other secondary outcomes, including point prevalence abstinence and at least 50% reduction in smoking consumption or cigarette consumption. That has been shown to have some effect on health outcomes, as well as changes in clinical mental health measures and adverse events. Now, these are our results from phase 1. Recruitment rate, target 6 per month per trust. If you've ever done any research within the NHS, you may not be surprised to find that we didn't meet that target. In fact, we only recruited 1/3 of those who wanted to recruit, so 2 per month per trust, and we varied quite differently, quite a bit between the different trusts, you can see. So that target, unfortunately, was not met. In fact, our trial was delayed several times, including because of COVID, etc., etc. So we wanted to finish recruitment in July last year, and we stopped the trial in December last year because we still hadn't recruited the requisite number of participants. And just to highlight again that there are quite a lot of differences between the different trusts that we involved. Some of the trusts didn't start recruiting until around 6 months into the trial because of various problems with the setup. Some of the trusts, such as Bradford, recruited actually quite well and nearly hit the target that we set them. In terms of the recruited sample in the end, we got 43 participants, equally balanced between the control intervention group arms, and there were no differences except for employment status, with more participants in the control group being in full-time employment. In terms of the consent or conversion rate, as well as attrition rate, so our target was 50% consent of those who are eligible and less than 30% attrition. And what you can see again, there's quite a lot of difference between the different trusts. Overall, we met our consenting rate at 1 in 5 being consented, but we missed our target on attrition, slightly more than 30% dropped out. So the target was partially met only. Now the effect size. So just to quickly explain, we used something called the one-sided confidence interval approach. Essentially, it's a sort of Bayesian analysis. What we're trying to show with our feasibility study is that if there was no difference between the intervention and the control group, we could definitely exclude a meaningful effect size from being present. Basically, we're trying to prove a negative. There's nothing going on here. Because we didn't achieve the target sample size, it's difficult to conclude what we can say about the trial. Was what we did find is there was a difference, which is positive. In fact, although it is quite depressive to some degree, you can see in the control group, nobody stopped smoking at all. In the intervention group, about 1 in 10 stopped smoking, 10% of the participants. In complete case analysis, it's higher because we don't count people who have not been followed up as continuing smokers. And because we couldn't therefore do our one-sided confidence approach properly, we took something called the scale confidence interval approach, which tells us something with the confidence we can have that there is something going on here in terms of differences. And what we find is that we have something like a 75% confidence interval that excludes there not being effect, meaning that we have some evidence of some signal that the intervention was effective. So more people in the intervention stopped smoking than in the control condition. So it's a bit unclear, but we can conclude from that. In terms of adherence and contamination, we found that about 2/3 of participants were using e-cigarettes in the intervention arm, which is good, which we think is acceptable level, and relatively few in the control group actually used e-cigarette when following them up. In terms of acceptability, participants thought that the e-cigarette was comfortable to use, and they rated highly in various characteristics in terms of size, shape, feel, and branding. And most, so that's 2/3, found the clinician-advised leaflet and leaflet useful, information easy to remember. In terms of other outcomes, this is agreement with whether they had a problem using the e-cigarette. It's about 1 in 5 had a problem using the e-cigarette. In terms of the burden of using e-cigarette, most found it quite not very burdensome. In terms of the amount of time that was spent describing the e-cigarette to them, everybody agreed they had sufficient time. In terms of being happy to learn about e-cigarettes, they also agreed that they were happy to learn about e-cigarettes as a tool to stop smoking. And in terms of overall positive experience of taking part in the trial, most agreed they've had a positive experience. So we think that this target is met as an acceptability outcome for the intervention. Now these are some of the secondary results, and here you can see point prevalence, absence, intention to treat, which is more strict, and then point prevalence, absence in complete cases. And what you see is for all of those, and then also a reduction of cigarettes by at least 50% at follow-up. And what you can see here is there's a meaningful difference for all of those across the intervention compared to the control condition. So people were more likely to be absent when we asked them at that day, and they're more likely to reduce cigarette consumption by at least 50% in the intervention compared to the control group. In terms of mental health outcomes, we found no differences from baseline to follow-up between the intervention control group in terms of the GAP7. In terms of PHQ-9, we didn't find an overall difference, but we did find a reduction in thoughts in the intervention compared to the control group on the item that they had thoughts that you would be better off dead or hurting yourself in some way in the experimental group, but we didn't find that in the control group. So basically, suicidal ideation was reduced in the intervention group. In terms of serious adverse events, none were reported. In terms of adverse events, we did find a high number of participants reporting these in the experimental condition, including lesion, nausea, irritation, depression, restlessness, etc., etc. The eagle eye among you will notice these are standard withdrawal symptoms. So what we think that means is actually that people may have been under using the nicotine e-cigarettes, and so therefore, because they've been abstinent, or more people were abstinent in the intervention group, they felt more withdrawal symptoms. In terms of the quantitative analysis conclusion, then we found the trial as it is at the moment not feasible to conduct because of recruitment and follow-up rates. We did find moderate to high levels of acceptability, and we found a suggestive effect of possible clinical significant effectiveness on abstinence. We found strong evidence for the reduction outcome, which is also part of harm reduction, obviously, 50% reduction in cigarettes smoked, and we found suggestive evidence on impact on mental health, and also slightly more adverse events in the experimental group. Just quickly want to go through the qualitative analysis that supplemented the acceptability analysis that was quantitative. So we interviewed various participants in the trial, but also researchers and clinicians, and undertook thematic analysis. And we found 4 main themes around evidence of acceptability, improvements to the intervention, issues with the e-cigarette, and improvements to material and procedure. Because of time, I have gone on for 11 minutes. I'm going to just give you the headline findings from the qualitative analysis. So essentially, participants, as the quantitative analysis showed, were happy with the communication and the e-cigarette itself. And researchers and clinicians agreed that it was a useful thing to address smoking with this population. Specifically, because information was coming from clinicians, as we've seen already, Debbie's talk, people have quite a lot of wrong perceptions about e-cigarettes and how harmful they are. So the clinician tells you this is a useful tool for you to stop smoking and it won't be very harmful for you, then they're more likely to endorse it. So that's a useful outcome. And participants were generally happy with the e-cigarette and the leaflet. However, the clinician said that they didn't find that 5 minutes was sufficient time to discuss this with their patients. And they're basically were too busy to provide all the support that the participants or patients required with the e-cigarette, and the participants also wanted more ongoing support after the brief intervention. It's a very brief intervention, essentially you give you a starter kit and you get a leaflet. People talked about the questionnaires being too long and cumbersome and repetitive, which I agree, they were rather boring and long and cumbersome, and they required more research support than anticipated in terms of the filling out the questionnaire, so it was a special population, and with the calls afterwards to complete follow-up. So the main barriers we encountered was recruitment, attrition, and some of the trust and terms of intervention, some of the content, some of the delivery, and some of the research processes and materials. Now, I'm not going to expect you to read through these, but these are the mitigations that we propose to the funder to overcome some of these issues. In terms of the recruitment, I can just highlight that because that's our main issue, is that we are going to select trusts more carefully and give them a list of things that require them to do or agree to in advance of participating in the trial, including being able to see participants regularly, so there's attrition, clinicians having sufficient time to deliver the intervention, and there's enough room to deliver the intervention or take people away to consent them, first of all. And we're also going to change the e-cigarette if we go forward to the full trial to something that's much easier to use, essentially something under vapor, something like this, where you don't have any control over it, you just plop something in, and that's it. Whereas with the other one, you would have to unscrew something, you have to change the coils, and you have to put e-liquid in. So this one's much easier to use than this being used in another study at the moment. So we hope that once, if we get funded, that we will overcome some of the recruitment issues, given that there was some signal of effectiveness of this trial. That's me done in 13 minutes, sorry.
Very good. Thank you. Thank you very much.